Hi, this is Brian Kim. I'm going to share with you case number 39 in the best way to do cataract surgery series. This is a small pupil that's a little bit floppy, and it's about a soft to a 1+ dense lens. And you're going to see how I do a typical soft cataract small pupil case. Again, the way I do the techniques is double chop, cross chop, mechanical fracturing, prolapsing pieces out of the bag, try to do a minimal trauma on the zonules. And so by doing it this way, I feel like I'm able to do these cases, even though there's a small pupil, very easily without much difficulty. So I use a cotton tip to center the eye, and I use a corneal marker to help me center and size my rhexis. I'm still using the cotton tip to manipulate the eye towards the left, and then make my paracentesis incision on the right side. Again, I'm staying parallel to the iris plane to create a nice corneal shelf. And then I make an incision on the left side in a similar fashion, and this helps assure that I'm going to have a self-sealing corneal incision. I'm injecting some intracameral lidocaine and now some intracameral epinephrine. I'm carefully going around and injecting and exposing the iris to the epinephrine to help stabilize this floppy iris. And then I'm injecting some dispersive viscoelastic, which will help visco dissect that pupil. So you can see it's a pretty big pupil, but don't let that deceive you. As the case progresses and the viscoelastic comes out, the pupil will come down. And so that's why you need a technique that's not going to rely on the pupil size. And so I'm going to do my triplanar corneal incision. I make a vertical groove, place the blade into the groove, tunnel through the cornea, and then dive in. And I use the cannula to help me control the eye. And this is with an indirect technique because I'm not holding the incision. I'm just leveraging the incision indirectly with the cannula. Then I do my puncture style capsular rhexis, puncture the center, pull down towards the incision, grab the right side and create a flap. And then I'm going around circumferentially, following the corneal marks that I made before to help me center and size the rhexis. Make sure I grab and re-grab every few clock hours, making sure that the rhexis is very well controlled. And then I finish the rhexis here. Burp a little bit of viscoelastic as well as the cap. And this is the capsular fornix hydrodissection technique. I place the cannula out to the contralateral equator, point the tip down. I get a nice fluid wave. I'm freeing up the anterior capsule on the left side, and then I place the cannula out on the right side and rotate it, and you get a nice rotation, freeing up the lens. So this is a phaco. I'm irrigating the cornea first, and then I'm going to lift the incision and go in with the phaco with irrigation off to minimize Descemet's trauma. And I want to remove the surface epinuclear material. This gives me a little bit of a landing place. I place the chopper out underneath the anterior capsular rhexis edge. I turn the phaco tip subincisionally vertically. I bring both instruments together and I crush the entire lens in half. And this is a double chop. So I place the chopper out to the contralateral equator, crushing the lens and pulling it centrally towards the phaco tip. This allows me to crush and divide the right heminucleus. I use some high vacuum to pull that first quadrant up, and then I use mechanical fracturing to crush the lens pieces into smaller pieces, and then using high vacuum to remove the lens piece. I use a chopper to pull that second quadrant up out of the bag, and then with high vacuum, I'm just teasing that lens up and removing that second quadrant, again using high vacuum. I turn the lens in front of me, place the chopper out to the equator, place the phaco tip deep, crush the lens with the chopper against the phaco tip, and I use high vacuum to pull that third quadrant up. I'm teasing it with the chopper to get it in the right position to remove the lens piece. Place the chopper out to the equator again, pulling it centrally towards the phaco tip, crushing the fourth quadrant in half, and then using high vacuum and using mechanical fracturing forces to crush the lens pieces into smaller pieces, and then removing the lens pieces with a high vacuum. And this is the final piece. I'm going around the lens piece and then using high vacuum to pull the lens up out of the bag. And I'm just very carefully using the phaco tip as well as the chopper to direct the lens piece so I can chop it and then emulsify the lens piece with the high vacuum. Now this is the epinucleus. It comes out quite easily at this point. I take the chopper out, push BSS in through the incision, take the phaco tip out, and then switch it with the INA handpiece. And this is my way to keep the chamber as stable as possible. I go subincisionally first, getting the cortex, getting good occlusion, and then pulling it out. Getting the subincisional is just a lot easier in my opinion, because you can be a lot more aggressive in removing the cortical material since the remainder of the cortical material is still intact. And I'm going around circumferentially and using that high vacuum to help peel the cortical material from the anterior side towards posterior side. Once all the lens material is removed, I go to the polish mode. Because this is a smaller size pupil, I'm very careful when I polish underneath the anterior capsular rhexis edge, because if you use too high vacuum and if the pupil is small due to zonular disease, you might actually grab the capsule and then end up pulling the zonules, which is not really a good idea. This polish mode is really excellent. I can be very aggressive with teasing off cortical material as well as lens epithelial cells with no worry that it's going to cause any capsular damage. So I'm just taking my time going underneath the pupil edge, underneath the anterior capsule edge, and just polishing along the underside of the anterior capsule. And then I start polishing the posterior capsular surface as well, making sure there's no remnants of any cortex or lens epithelial cells. I place the cannula through the side port incision. I turn the INA handpiece away from me. I pulse BSS into the subincisional space, but it looks pretty clean here. I inject some cohesive viscoelastic and then start to sweep the left side. You can see the pupil is quite big now, and again, I think this indicates this patient has a floppy iris situation. I polished the left side and now I'm polishing the right side as well, trying to remove any lens epithelial cells. It looks pretty clean though. I inject the single piece acrylic intraocular lens into the capsular bag, delivering the leading haptic into the bag. I leave the rest of the lens out. I go in with irrigation, which inflates the eye and the bag. I make sure the leading haptic is disengaged from the optic, and then do the same, making sure the trailing haptic is disengaged from the optic. I go under the lens, tilt it, and I rotate it 90 degrees clockwise. And by tilting it and angling it away from me, I'm making sure that both haptics are indeed in the bag. Remove all the viscoelastic from within the bag. I'm tapping it down, and I'm trying to remove some viscoelastic in the chamber. You see I was able to snag that iris very easily without much effort, even though I wasn't too close to it. I believe this pupil is a little bit unstable, so I want to just stay right in the middle so I don't snag the iris again. You can see the iris is really billowing pretty aggressively here. So I do think that this technique that I use does minimize the risk for iris prolapse. So before I pull the INA handpiece out, I turn the irrigation off so I don't allow that high pressure to cause the iris to come out of the incision, and then I hydrate my incisions. So again, this is a soft lens. I didn't use any ultrasonic energy, a small pupil. Again, with small pupils, people are scared of placing the instruments out. Again, if you have to rely on spinning the lens and sculpting, it can be a little bit of a challenge for small pupils. With chopping, again, people can be uncomfortable to chop if they have no good visualization. But with this technique, it is not based on visualization. It's purely based upon feel and knowing where your instruments are and using mechanical fracturing forces to divide the lens pieces, pulling the lens pieces out of the bag. This is particularly helpful for the soft lens. So I hope this was helpful to you, and I thank you for your attention.